Thank you very much, Dr. Kannan, for this kind introduction. I'll be very brief in my presentation so as to have some time for discussion. Now, this new, the old wine in the new bottle is the actual understanding when you talk about MRDM or malnutrition-related diabetes versus type 5 diabetes. Though the Western world has started realizing it now, but our senior people, our mentors, almost 50, 60 years from now, in 70s, we had got the paper on IRDM or malnutrition-related diabetes. I'll cover that also. So today's talk is dedicated to all my organizing person, my mentor, Padma Shri, Dr. V.Mohan, Dr. Ranjit, Anjana, Guha Pradeepa, and the whole team. So Vanakkam to every one of you for this session. I don't have any conflict of interest. We'll have introduction. What is this IRDM or insulin requiring non-ketotic or ketotic resistant diabetes and malnutrition related diabetes? It's basically a synonym. And then we have the subclassification of this diabetes into two: PDDM, protein deficiency diabetes mellitus, and fibrocalculous pancreatic diabetes. Do we have any clear guidelines? If not guidelines, at least a clue that how should we control hyperglycemia in these patients when both of them need insulin along with type 1 diabetes. So now you have three categories: type 1 requiring insulin, you have FCPD requiring most of them insulin, and you have PDD also requiring insulin. How do they differ from each other when it comes to requirement of insulin? Some message on those lines may not be the RCT. So this classification, I don't need to go in detail of it, but unfortunately in this era, we don't have the place for type 5 diabetes or MRDM, which was there long back. Thank you, Dr. Ashirvachan, so that you have saved some time. But then when you talk about type 1 diabetes or anyone who is requiring insulin, any adult coming to you who is around 25 or 30 years of age, and you seem to have a low C-peptide, severe hyperglycemia, symptomatic hyperglycemia, you have multiple things in your mind, and one of them is type 1 diabetes, which I don't want to go in detail of it. Get their C-peptide done, get their antibody testing done, and if it is positive, it will be a autoimmune type 1 diabetes. If it is negative with ketosis, then you could diagnose as type 1 diabetes, and basal bolus therapy becomes a drug of choice for type 1 diabetes. No big deal when it comes to adult person coming to you like this. But if such same adult comes to you with 600 and 800 blood glucose without ketosis, C-peptide is low, no antibodies, then what is your diagnosis? One says I take alcohol, another says I don't take alcohol. So two people again, alcoholic, non-ketotic, non-alcoholic, non-ketotic. Get your X-ray done, you find some of them have shadows of calcification in the pancreas. You label it as FCPD, fibrocalculous pancreatic diabetes, but one has history of alcoholism, another does not have a history of alcoholism. You again reclassify, oh, it's a tropical. It's a tropical FCPD. Alcoholic, you have a etiology, so alcoholic FCPD. But another person does not have anything. Low C-peptide, no antibodies, very high blood glucose, no ketosis, 5 years taking oral drugs, metformin, glimepiride, all those family physicians, they go on giving these patients. They remain on hyperglycemic state for months and years together on oral drugs. They never come to any tertiary care center because they are very poor. And then one day, fine day, they come to with cachextic state, and then you diagnose them, oh, this seems to be IRDM insulin requiring diabetes, no calcification in the pancreas, but this poor fellow belongs to a family where they don't have possibly money to eat. So they are very poor from the poor family. So this is how you actually, I just summarized it before you go for the text. So officially recognized by IDF now, April 8, 2025, at the World Congress Bangkok, and earlier it was called as malnutrition related diabetes. Around 20 to 25 million people, mostly in low and the middle income group, Asia and Africa. They are lean, they are adolescent or young adults, and they have chronic undernutrition. That's a hypothesis again. So first detected Jamaica 1955, then 1985 it was, if you have seen the slides of Dr. Ashirvachan, it's shown those. 1985 you had another category, MRDM. Then we had IDF in Delhi, and that was in 1994 or so, and that even before that, 1980s, late 80s, and that IDF was shared by one of the person from Delhi, Dr. J.S. Bajaj, and that time we have included in 1885, we have included MRD, malnutrition-related diabetes, which remained there till 1997, if I am not wrong, but it was again removed it from there. And they say all such cases are secondary diabetes or other type of diabetes. They are pancreatic diabetes, and they are not given it a separate classification. But thank you to Schwartz that he has actually now has classified it as type 5. So this is about the president of Professor Schwartz, that he has mentioned the recognition of the type 5 diabetes makes a historic shift in how we approach diabetes globally. For too long, this condition has been unrecognized, affecting millions of people, and depriving them for access to the adopted care. With the launch of type 5 diabetes working group, we are taking decisive step to correct this, and this is about equity, science, and saving lives. These are his words, and now we have type 5 diabetes, which is MRDM. So it is being classified as severe insulin deficient diabetes. We know type 1, type 2, everyone knows about it. Type 5 is impaired pancreatic development, possibly because of the chronic undernutrition due from childhood to adolescent. And there is another hypothesis, undernutrition in the pregnancy. What Professor Shashaya Padmashri said, he taught us, our mentor, that possibly the nutrition, intrauterine nutrition is the culprit. And if you have maybe a hypoproteinemia during the pregnancy, or poor intake of protein and some other important micronutrients, that could be causing a poor development of the beta cells of pancreas, which ultimately fail to respond to your glucose or other things at the adolescent and adult life, and they ultimately need insulin therapy. Represent a unique clinical entity across. This is again a Hawkins data, which has actually seen around 73 lean Asian studies, 20 met the type 5 criteria, showing finding disapproved the insulin resistance theory. So there was no insulin resistance. They have severe secretory failure, the beta cell secretory failure. They have low hepatic and visceral fats. And that is why they are possibly ketotic resistant, because they don't have enough fat to get converted into ketones. Enhanced glucose uptake and reduced endogenous glucose production. They still have little amount of insulin. If you do the insulin, the C-peptide levels, if you say for type 1, it should be less than 0.4 or 0.6. And if you talk about type 2, we say more than 1.1 is normal. So when it comes about IRDM, your C-peptide will be between the two range. That's how you define. So key features: early onset in the age, maybe before 30, but we see even 35, 40s also. Low BMI, very low BMI, less than 18.5, and no ketone, unlike type 1 diabetes, rarely experience ketosis. Misdiagnosis, often they remain as type 1, or they are being kept on type 2 because they are adult, and they remain on tablet without getting control. Poor socioeconomic background, and insulin resistance is not to be seen in most of them. Additional feature, they have low insulin secretion, high glucose production and uptake, and lower level of visceral fat and hepatocellular lipids, unlike type 2 diabetes. And now, how do you connect type 5 and type 2? And of course, nutrition possibly is one reason here, that 45% had at least one key deficiency of some nutrition, maybe vitamin D, magnesium, iron, vitamin B12. Nothing has been proved that this particular drug is causing this, but then this could be one of the area of research. Acute complication, they don't develop ketosis despite having 600 and 700 blood glucose. So they have infections like fungal infections, scabies, pulmonary tuberculosis common. Hypoglycemia reported as a major cause of death in Uganda. No hospital death in recent years. Severe periodontitis also been seen. Chronic complication, yes, they are more prone to have microangiopathy. This has been shown by multiple studies. So painful neuropathy is very, very common. So one of the IRDM patient with 600, 700, HbA1c 21.5. HbA1c was 21.5. He was brought like this in the clinic with around 891 or some blood glucose, and with HbA1c 21.5, and he was admitted for around 4 or 5 days. He just required insulin therapy, nothing else. And of course, vitamin D and all, calcium, magnesium, we did do that. But when he was discharged after 4 or 5 days, he went walking back home. And that was the end. And he was diabetic since almost 5 years. No one has treated it with insulin. Everyone is just giving tablets. So then cataract, retinopathy, nephropathy is common in this age. Primary causes of the death is overwhelming infection. Ketoacidosis is not being mentioned too much, but nephropathy, macroangiopathy is rare, and loss to follow-up is one of the cause. Now, subtype, as I told you, MRDM has been subclassified into two: FCPD, fibrocalculous pancreatic diabetes, and protein deficiency diabetes mellitus. This is very early classification from Dr. B.B. Tripathi, G. Varghese, those days in early 70s when possibly I was in 10th or 7th, 8th standard. So FCPD, just to be very brief, this is how the calcification looks like. If you can appreciate, I don't know whether I have a pointer working here. Yeah, this is the calcification of the pancreas. You can see simple plain X-ray abdomen will diagnose it. If you have a established calcification, but there will be little gray zone that I'll show you. Overview: a form of diabetes secondary to tropical calcification, calcific pancreatitis, primarily affect the poor, lean and malnourished, common in southern India, even in central part of the India. Key features is recurrent abdominal pain since childhood. Adolescence may be dilatation and fibrosis in the calculi in the pancreatic duct, and then adult life insulin requiring. Ketosis is rare. Complication, long-term complications of diabetes will be there, but then such patients may come to you with exocrine dysfunction of the pancreas. So they will tell you, I am passing stool which is like oily. So passing oily stool is one of the clear-cut sign that possibly this patient has chronic pancreatitis, exocrine failure also, which is rarely seen in type 1 diabetes. Severity and they remain on insulin therapy. Most of them, they require insulin. Ketosis is rare, and C-peptide will be low. Classification, classical features, this is as per the G. Varghese classification: extreme emaciation, cyanotic lip, bilateral parotid enlargement, abdominal distension, 25% malnourished, 70% remain lean. Abdominal pain is common, and of course the exocrine dysfunctions. So GI symptom will be 33% will have oily stools and steatorrhea. Pathogenesis: undernutrition at the time of in the early childhood or intrauterine. Cassava has been quoted, but again there were some reports which are contradictory. So someone says cassava in the South India and the Kerala might be reason. Familial genetic micronutrient deficiency, oxidative stress and other things have been also quoted. Ketotic resistant: why despite having high blood glucose they did not develop ketosis? This was the question which is going to be asked to everyone. So it was proposed that it is possibly they have little more beta cell still alive. I told you it will not, few of them will come to you with even 0.2 also, but then most of them will be between 0.4 to 1.1, maybe 0.7, 0.6, 0.8, something like this C-peptide, not exactly matching the figure of type 1 diabetes. So some fetus are still there. Alpha cell restriction, so low glucagon, less ketone stimulation, low subcutaneous fat, as I had already told you, adipose lipolysis and resistance to the adrenaline, and carnitine deficiency has been quoted, one which I am not sure about. C-peptide levels again will be intermediate between the NIDDM or type 1 and type 2. Some patient will have negligible C-peptide but still no ketosis. Additional protective mechanism is not exactly known, and we have to possibly work on this. Exocrine dysfunction must be there, as I told you, and we need to give supplement with the pancreatic enzyme. Diagnostic criteria: usually in the tropical countries, and then they will have evidences, as I told you, in the X-ray, and maybe either CTX, either sonography or CT scan. Now here important thing which I have learnt while studying and giving these papers: you will have two types of calcification in the pancreas or anywhere in the body when you talk about calcification. One is a soft calculus, one is a hard calculus. This CT scan radiologist has taught me, sir, that soft calculus may not be picked up with plain X-ray abdomen. You'll have to go for CT scan. So we might be missing out some of the FCPDs which are actually classified as PDDM because there is no calcification in the plain X-ray abdomen, for which you have to go for CT scan. We have to have again another food for thought, and for all those who are in the medical colleges, give some thesis on these lines. And of course steatorrhea. Radiological features, as I told you, I'll just skip these slide. Imaging technique, various techniques you can follow and do that. Chronic pancreatitis can be one of the thing. And this is another picture of the if you appreciate this calcification, can you see this? This is exactly pancreas shape, and you have all the pancreatic calcification across. About PDDM, again, you will not have the absence of pancreatic calcification is one of the diagnostic of PDDM. Radiological evidences will not have much of the abnormality. Malabsorption due to exocrine dysfunction, again, may not be there. Earlier, this particular category has been accepted if you don't have any obvious. If it's not type 1, it's not FCPD, it is PDDM. And we have observed, if you take the birth history of these patients, almost 95% have got home deliveries. And hardly 4 or 5% have got hospital delivery. Many of the patients have poor socioeconomic status, almost 70% of them. And if not, then possibly their mothers were sick at the time when the baby was intrauterine. These are some of the observations which we see. And the clinical features, I will not go in detail of it, but abdominal pain will be rarely there. Again, BMI will be less than 18, absence of ketosis on withdrawal of insulin, poor socioeconomic status, and most of them, they require more than 6 units of insulin per day. Again, important. When you give insulin therapy, admit them, shift them to basal bolus therapy, you will find they are requiring all pancreatic diabetes, as post-pancreatic diabetes or PDDM diabetes or even FCPD. You will require large amount of bolus insulin, very small amount of basal insulin. Exact reason is not known to me. Possibly the hepatic glucose output is not a very major issue here. Blood glucose will be coming hardly like what we have been taught in our textbook. When you give insulin, divide into 30%, 70% or maximum 50%, 50%, short acting 50%, divide this short acting 50% to 3 doses of basal bolus. If you have 50 units, 25 should be given 8 or something like this, and another 15 units should be, 25 units should be given as bolus, doesn't hold true for pancreatic diabetes. So again, this is a big learning to you. You'll have to, otherwise patient will come to you with nocturnal severe hypoglycemia and coma, and will come with convulsions. Sir, you have given me premixed insulin. So no mixed premixed insulin in such patients. They have to be on basal bolus therapy. They may require 20, and hardly 7 or 10 units of insulin long acting in the night. So that's the message for all of you. Again, pathogenesis, I'll skip this. They are ketotic resistance, and exocrine pancreatic dysfunction will be very, very common in most of these patients. Sonography, you should do it, and maybe CT scan, as I told you. And insulin requirement, of course, you have to measure accordingly. There will be some exceptions everywhere, which could be seen even there. Treatment, they will need little high calorie diet and complex carbohydrate. This is our oral presentation, which we did it last year in EASD, European Association for Study of Diabetes, and this particular paper was in Spain, Madrid. And we have around total 55,800 patients, and out of them, out of 60,800 patients, 55,000 almost were 92% were type 2 diabetes, 2.6% were type 1 diabetes, 4.4% were GDM, and 1.2% had secondary diabetes. Out of this 1.2, that's 700 patients with secondary diabetes have been classified in various forms, and we had around 300 patients who were classified as PDDM, and around 196 men and 100 female. And they were studied. So mean age of coming to the clinic is 45 years. But the mean age of diagnosis is 40 years. That means 5 years long period, they were on only oral drug. They were not given insulin therapy. Either they were on some powder or some alternative therapy, remaining on 600, 700 blood glucose. The mean HbA1c when they came, they had around 14. And mean, as I told you, highest I have seen is 21.5. We had 20 and 18 and 17 is not uncommon in most of these patients without ketosis. And yesterday it was 981. Yesterday one patient came to me. It was 981. No ketosis, not willing for hospitalization. Ultimately, I gave him my basic 8, 8, 8, 10, 10, 10, and maybe 5 units of long acting. Just go back, at least start insulin. He did that. Low C-peptide. So this patient also 20% had hypertension, around 6% in coronary artery disease. Retinopathy was most common, around 18%. Nephropathy 5%. Neuropathy 30%. Very common. Highest common complication is neuropathy and painful neuropathy. PAD very less, 1.4%. Dyslipidemia around 50%. Pulmonary COX was also seen around 7.4%. Positive family history was in the first degree is only 4.7%, and the second degree relative, first degree or 14%, second degree 4.7%. Tobacco smoking chewers was there, but they were all non-alcoholic. They were not alcoholic. Poor socioeconomic background is important, and low birth weight, as I told you, was important here. Birth weight data was not was available for all, but 180 subjects. However, whatever we had, almost 60% had history of low birth weight. Birth weight was less than 2.5 kg, and that could be one of the reason. And they require higher dose of prandial insulin. 76% of the patient of the total insulin is prandial insulin. Only 25% of the total insulin is. So it's not 30, 70 or 50%. It's 75 and 25% for short acting and long acting insulin. So to conclude this particular paper, insulin requiring non-ketotic or ketotic regimen is not uncommon in India. They are mainly from poor socioeconomic background, have low BMI, low C-peptide. They present with severe hyperglycemia symptoms, and they have severe maybe weight loss, but remain ketotic resistant. Unfortunately, their insulin treated is delayed by almost 4 to 5 years in India. At least in central part of the India, they are at higher risk of microangiopathy than macroangiopathy in relatively shorter duration of time. And type 1 diabetes, so if you remember, their total duration around 5 years from the diagnosis. 5 to 6 years, 5 years untreated, and 5 years they came to us. So maybe 8 to 9 years, but they have developed microangiopathy, which is traditionally should happen after maybe 10, 15 years. Unlike type 1 diabetes, they require more amount of short-acting prandial insulin than the basal insulin. These are some of the pictures of those IRDM or PDDM, protein deficiency diabetes mellitus. If you see the BMI, that will be 12 and 13. I have seen the lowest BMI I have seen is 12.1. In our clinic, and these are again the same patients of different ages. Some of them are even older. FCPD, I'm not going to go into comparison of both of them, but this is a little central obesity has been observed in this case. This is an alcoholic chronic pancreatitis secondary case. So with this I stop here. With this, this is my last slide, which is a traditional slide, with all chairperson who are sitting must have chaired my session multiple times. And this I show everything, and Baba Tarani's smile is again giving me more energy on these lines, that whenever you celebrate your birthday or the anniversary or any occasion in the hospital, don't cut the cake, cut the fruit. What did I say? Don't spoil your endothelium by taking hydrogenated fat. Your clapping should have been much more harder, you know. So from here onwards, cut the fruit and not the cake for any celebration. Vanakkam once again. Thank you very much for your patience.